Hi, good morning, everyone. Thank you for joining us. I'm Samantha, and I work with ACOs as the Director of Member and Partner Services. We are super excited for this opportunity to present to you our next installment for our free webinar Wednesday series. Today will be Value-Based ACO Models Distribution Roadmap Confirmation. Before we get started, I wanted to go over just a few items so you know how to participate in today's webinar. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions in the questions pane on the control panel. You may send in your questions at any time during the presentation. We will collect these and address these during the question and answer session at the end of today's presentation. With that, I would like to introduce to you John Wagner with the Value-Based Transformation, also known as the Berkeley Research Group. Thank you so much, John, for being here with us today and leading us on this discussion. I'll now hand it over to him.
Sam, thank you so much for the opportunity to spend some time with your group today. We really appreciate it, and want to start by kind of just letting people know who we are real quick, but not to spend too much time on it. Don't want it to come across like an infomercial, but we refer to ourselves internally as kind of one of the larger companies people haven't heard of. We're just recently ranked by Modern Healthcare as the 7th largest healthcare consultancy. And we view that we really kind of differentiate ourselves from other consultancies by having really deep industry experience within our group. And one of the roles that I play with the organization is helping to lead the value-based transformation team. So if I can ever be of assistance or you have a question, feel free to reach out. We have contact information in the back. Our goal for today is to provide some insight into kind of the strategic and operational opportunities that exist as you develop and evolve your savings distribution program. So we're going to go through some guidance background, trends, understand what guiding principles we recommend, different strategies and models that may help organizations out on their journey to value-based care. And before we jump into that, I do want to congratulate, since this is FLACO, which the F and the L stand for Florida, maybe the F, the L, and the A. I wanted to congratulate 4 of the top 10 ACOs for 2016 performance. Are all actually from the state of Florida. So we have Palm Beach, Cleveland, Millennium out of Fort Myers, and Orange ACO out of Miami. And so I think that's a great accomplishment. Florida is one of those handful of really kind of progressive and tough states, so that is a fabulous result for our group. So I thought this was an appropriate way to start. I think it's a great cartoon, and to me it happens a lot when we talk about distribution and how we're going to manage shared savings and how we're going to work that through the organization. And so kind of the literal interpretation of this is don't miss the boat on your distribution strategy. But as we've worked with different health systems, groups starting ACOs, as I personally ran an ACO and helped develop other ACOs outside of the state of Florida, one of the opportunities that I continue to see is the ability to really use the tool of your distribution strategy to help accomplish your strategic mission, and really look at making sure you have an operating model that promotes the cultural drivers that you want to have that are going to then promote success to your organization. So if you think about key things around alignment and transparency and buy-in, those work throughout the program a whole lot easier if they're built on the foundation that people believe that there's a certain amount of fairness, particularly as it relates to the way the financial rewards are going to be exchanged. So really do believe that this is a foundational component that really can help drive success of an organization. As we go into today's discussion, one of the things that we recognize is that the vernacular around value-based and ACOs, and all of this is broad and without a really good decoder ring at this point. So ideally, when we talk about who is distributing, it could be any of the models that are out there. It could be any of the value-based models, and ACO, clinically integrated network. Mostly, we're going to kind of anchor on the Medicare Shared Savings Plan ACO, but a lot of this is appropriate beyond just the Medicare Shared Savings Plan ACO. I know I have the opportunity to review a lot of payer contracts, and I have not seen a payer contract in a while that extends past a year that does not have some type of quality measures program integrated into it. But so for this conversation, generally we're going to anchor on MSSP ACOs, but it's appropriate across the board in many cases. I'll try to point out where there's something that's going to be just specific to one program or the other. And we're really talking about shared savings, but again, any incentive payment, quality-based payment, whatever else, HQEP program, a hospital quality and efficiency program savings, a lot of that, the thought process that we're going to talk about today is appropriate in those varying models. So just recognize that terms are going to be used interchangeably. Why did we pick distribution strategy to spend some time on today? We really do believe it's one of the drivers that helps with physician alignment. And what is physician alignment? There's a lot of different definitions and a lot of places we can go to with this. As a matter of fact, I just got done reading a book on the Insider's Guide to Physician Engagement, which talked about alignment. But really, kind of fundamentally, it's when the organization's goals and the individual physicians or those key players within your organization's goals align. And so how do you ensure that alignment occurs? And it's not really rocket science, but it's tough in business because there's so many different players involved, particularly if you're doing something innovative and new in an organization. So really making sure that we have common understanding of goals and objectives, that there's consistency between the organization's goals and objectives and the key constituencies, that there's a strong commitment to not just physician engagement, but truly to physician leadership and physician development. We spend a lot of time in the corporate environment developing people within the organization, and we do a lot of physician engagement where we put physicians in roles to provide leadership, but really making sure there's a strong commitment to developing physicians throughout these new programs. Ensure that there's a belief that we're fair, transparent, and that we can ultimately answer that really important question of what's in it for me, like why am I going to participate and what am I going to get out of it. So as we believe, and you'll hear me refer to this a bunch of times, we believe that the ultimate key is making sure that the distribution is in proportion to the contribution. And it's not always easy, but if you do that, it creates a solid foundation for alignment. So to talk, spend a second on the distribution strategy direction. As we think about the approach going forward, within the organization, there really is an opportunity to reinforce key strategic goals through how you develop and communicate your distribution strategy. In many cases, this is missed. The oversight and overlooking it or missing the opportunity to do that, really it's hard to, I'll use since we started off with the arc leaving, it's hard to paddle backwards, right? So we really want to make sure that early on we're establishing buy-in, creating that transparent environment throughout the development stages of the program. We're aligning the incentives and their efforts, and we're reinforcing what's important. And so as we do that, that really makes sure that the results of what we're driving to are going to be more easily obtainable. Now, from a strategic standpoint, we have to make sure that whatever strategy we have in place is supported by the regulatory guidance. And for many of us that have been involved in CMS at a very deep level and across the host of programs, generally there is a plethora of guidance, probably more guidance than most of us want to have. Well, as luck would have it in this space, not really so much. The regulatory guidance that's it's in section 425.204D. There really is more directional information provided around your shared savings distribution than there is a really intense criteria. And actually, most of it is really how you're going to use the shared savings. CMS wanting to know how you're going to use the shared savings among your ACO participants, and then somehow are you going to use that to help obtain the triple aim. By the way, you can tell number 2 is missing on here, and number 2 is part of this reg is really they want to know how you're going to achieve specific goals of shared savings. So there's an opportunity for us to make sure that what we're doing really decks up against strategically what we're trying to get our ACO to drive towards, which is that higher cost, lower cost, higher quality, and improved patient satisfaction as we move forward. And that we're really lining up incentives in the manner that really best helps the ACO accomplish those missions. So if we understand our organizational strategy and we have a good feel, or we understand that the guidance provides us a little bit more of a open whiteboard than other components of the shared savings programs, then really understanding how we use those and to help play out the specific goals of our specific value or ACO. And what this slide represents is strategically there's a lot of different reasons people set up their ACOs or their clinically integrated networks. If you look to the left of the page, market expansion, this is really kind of a long-term strategy. We make investments in the professional network, tends to have more of a commitment to infrastructure improvements. It's a long-term, generally earlier to market play. There's the market dynamics of a competitive reaction, which is more of a protective action, whether it's the payers are coming in and partnering with different folks, whether you're in a very competitive marketplace where others have started to develop ACOs in advance of your organizational commitment to do such. And within that dynamic, there's different factors to consider as we think about our distribution strategy. One of the things, and I'm actually going to spend a few minutes kind of on a little bit of a digression talking about founders payments in a second, but founders payments are a great opportunity and a great tool to use if you're in a more of a reactive position than a early to market position. What we see in this competitive reaction mode is there tends to be less shared savings directed towards infrastructure investment and more because some of it has to be redirected to the founders payments. And in some cases, folks will even choose to do a little greater percentage of incentive to specialists, particularly kind of that tier 2 CMS specialists where they can have some attributed lives, but also because they tend to be the types of specialists, cardiologists, nephrologists, et cetera, that are really critical referral partners. And so you can see that gets layered in. And then the right side of the page, the ACO performance component, this tends to be more of an investor model. So what we know, at least for a little while until we understand what our new numbers look like with all of the 2018s coming in, is that about half, or roughly half, of all the MSSP ACOs are physician-led, and half are models without a physician component. And even in our top 10 in the Florida, we have both models that have performed in the top 10. So a ACO performance model may be more inclined to be a physician-only model, may be more inclined to have a stronger investor-owner model where there's been investments made and need to be recouped. And because performance is a stronger driver, you may see incentives tied to things like leakage, just keeping referrals into the network at a little higher percentage than some of the others, because there's a little bit of a less strategic priority on some of the longer-term relationships. So it tends to be a single line of business only focus for the leaders in that group. We lay these out just because it's important that we understand, okay, why are we doing what we're doing, what influences what we're doing, and then how do we build upon that as we think about our strategy moving forward. Now, I promised that I'd spend a minute on founders payments. They always seem to be a topic of discussion when we're with a new health system. You know, should we do them? Should we not do them? You know, why do you do them? So as we kind of surmised and summarized what we've been dealing with as it relates to founders payments, came up with what we believe is important to help people be successful related to those. It's really clear to define who and how and why you have a founder, and what does it mean to be a founder, and what are your expectations from those founders. It can be as simple as you just signed up first by a deadline. Generally, that's underplaying the asset of founders, because you're going to, in many cases, compensate them for being a founder. The idea is to layer on some opportunity to make sure that you're getting the type of engagement and leadership you need. We've seen this done a bunch of different ways, but generally believe that founders should be limited to those that bring in either attributed lives or are key strategic specialties for your local market. And you kind of have to leave that second half of the sentence up to the local market, whether it's key business partners, whether it's key referral partners, you know, just key leaders in the marketplace, or folks that work with your system in different ways. So, but we've seen where we've had a health system use a deadline type method, and so just recommend that it gets focused. But all the methods can work, and it's really around your health system. Recommend that founder incentives are limited. They tend to have a pretty nice a chunk of shared savings if shared savings is obtained. But most of the ACOs are established to either grow in size or grow in the types of contracts that are layered in. So once the organization evolves, gets better technology, really starts to grow, we really ought to age out that founder's payment, and require, by the way, that founders remain in the network to receive payouts. So that to me is an opportunity, because in the past we've seen a few examples where a lack of clarity created some issues. And then kind of the last kind of founder incentive piece that we think is important for those that really need to use the founder method to help grow their network initially is to consider tying them to the first payout year versus the first year. So one of the things we know statistically is the longer a system is in the ACO program, the greater the likelihood of shared savings. So getting more sophisticated, evolving, and improving increases your odds of payout. This allows two things to occur. It creates a stickiness of your network, you know, folks to stay in because that carrot's out there until shared savings is obtained, and it ensures a positive outcome of the experience of being a founder, because there is ultimately a payout. And so as we have talked about founder payments, we look at that as kind of a cheat sheet or a set of guiding principles that help folks out as they're thinking through the use of founder payments or not. So as we progress, I'm going to talk about some current trends in distribution. And this is more kind of the traditional investor model. If you look on the right side of the page, what's been reported, this has been reported in a couple of different sources, but the bulk of ACOs report that in their distribution plan, there is some fund set aside for either covering up operating expenses or reinvesting in infrastructure. Infrastructure is much more common than covering of operating expenses, and I think that probably also depends on whether you're an investor started model or a hospital system started model, or as to how operating expenses tend to be covered. So what that 85% works out to is about a third of all shared savings is targeted to be reinvested, which just me personally, after seeing some of these numbers, that was a little higher than what I had anticipated it to be, but in general makes sense. As we see kind of the hierarchy of payment, generally what we see is if there's an investor involved and they've made significant financial contributions in getting the ACO or the integrated model stood up, there's typically some percentage of savings to recover investment out of shared savings. The next level is for operating expenses and required investments, and then the remaining is paid out to the network, with the primary care or the group bringing attributed lives generally getting a disproportionate share, and then hospitals that are non-investors but partners and sometimes specialists. And so that's the flow. And on the next page, we'll see a literal or a graphical interpretation of that. It's kind of a full-blown model. So we don't see all of this all that often when we're talking to systems, but just kind of wanted folks to have the complete model and then to be able to adapt that thought process to their specific arrangements. In this, you'll see that it starts with shared savings, and then we have CMS taking their half and the ACO taking their half, although their half is very rarely 50%. So almost more there to be to kind of point that out, but your quality measures bounce off to get that. So rarely is that 50%, actually 50%. But that be what it may. If you have an investor model, you'll see some split at the investor model. If you have then that investor model creates a legal entity or a joint venture, there can be a part of the savings that goes to that model. And if this is a hospital-centric hospital partnership model, they would get a percent, physicians would get a percent, and of that, the bulk goes to the primary care, and the lesser percent goes to the specialist. And these, by the way, are not recommended percentages. They're just to allow us to kind of walk through a more complex model. There's other things that just drive how you're going to do payouts. There's also different lines of business. If there's a relationship with multiple ACOs involved. A physician-only model with an investor is going to be different than a hospital and physician JV with an investor. And so all of those are just going to impact what you do. But I was looking at this model, and I was just kind of running the numbers that if you started with 20 million in savings, what would that ultimately get you besides on the top 10 list? And you split the 20 million 50-50, that's 10 million. The investor takes 5, you take 5. And as you work the math down, the actual, in this example, for 20,000 lives at a $20 million payout, you're really looking at something that's like $35 or $36 per penny. and if you had an average of 50 bennies, it's a couple of grand for primary care. So the very complex models really do have the overall impact of not necessarily making feel like there's good alignment of incentives for those that are driving your outcomes. So as you think about upstream and who gets paid what, really understanding how the math works is critical. So if we break down these participants, investors, there tends to be a series of different ways investors can be involved. They can either be part of the organization, it can be a joint venture. Their expenditure should be clearly defined with a cap or total limit to pay out. Have heard of a situation where there was purely a VC type investor involved with an ACO, where there was not there was a percentage of return without a cap that limited them to some component of, or to what they invested plus some profit, and that ended up as an ugly outcome. So as folks are putting together these types of arrangements, understanding that assuming a success and then how you drive that is really important. When you talk about the ACOs, value-based operations, recently it was reported that it takes about 1.6 million a year of investment in operations, and then to maintain infrastructure, not necessarily to expand infrastructure, on a average ACO. Now, ACOs are, if you've seen one ACO, you've seen one ACO. There's a 30 physician-owned ACO that has very different infrastructure and infrastructure requirements than one that's operated by a 10-hospital system. But just to kind of put a benchmark out there, so it's important to establish a multi-year plan for what investments are going to be used for. That we generally suggest that there's some form of governance committee that has accountability for keeping the plan current, understanding the implications of previous investments, and redefining what future investments look like. For this presentation, we did not really spend a lot of time talking about the corresponding governance infrastructure. That would probably be an hour in and of itself for those who have been involved in that side of developing these. But recognize that really when it comes to investments and operational investments, there really benefits that's a technology work group in place that has that accountability. And then we also recommend that, particularly for a hospital system that's established an ACO via a legal entity, that you establish a management services agreement that really clearly defines which services are shared services versus which require self-funding, and then on future developments how you want to set those up, because that has the opportunity to taint positive shared savings distributions if that pre-work isn't done. Now, the breakdown of the provider participants, this is probably the component most people are most familiar with. What we generally see is in a physician-only model, the bulk of the network payout goes to the primary care. Matter of fact, in most of the ones we've seen, it's closer to 100. There are a few that do some other types of payments based on other extenuating relationships, but it's really most of the money going back to the primary care physicians or the physicians with attributed lives. Hospitals, generally significant early savings do come from the hospital. So if a hospital is a key component of your model, they tend to receive a little lower on the payout. A lot of that, and this is really as part of the delivery system, not necessarily as part of the investor group, but we see a lower percentage in the 25 to 50%. An interesting thing that came out from the CBO, the Centralized Budget Office, recently, is the impact of MACRA is going to be a reduction in about $250 billion from hospital systems by 2030. So in the next 10 to 12 years, whether it's the impact of MIPS and the way they drive quality measures to do certain things, or the impact of APMs associated with NACRA. So APMs are ACOs and bundled payments in the patient-centered medical home programs run by CMS. Much of that $250 billion is really going to be a displacement of the inpatient admits or redirection from secondary services. So when a hospital is a partner, recognize that if a bulk of the payments or the bulk of the shared savings comes from that effort, and the hospitals are working on that effort, that doing some recoupment of that is appropriate, just like it is with the primary care, helping bring the lives and manage the care within. And then specialist, based on the model, we generally don't see significant portions of shared savings being identified for specialists in the nothing to 10, 12, 15%. In the more progressive models where they do set aside funds for specialists, it's really for targeted care programs with targeted outcomes. And there's a variety of ways to handle this strategically. So it can be handled in a budget model where the funds are set aside, they're put into a budget so that savings year over year as the savings model grows, as specialists invest in activities to lower costs of care. There's a program for recoupment. It can be on an annual basis, and we'll talk about that in a little bit more because there is some merit to that. But there really is a variety of opportunities there to help support the lowering cost goals. So let's talk about principles of shared savings. This is our list. We try to keep it manageable, but as we think strategically about these programs, there really are a lot of puts and takes that really help. So we believe that as you're developing your program, making sure that your own financial alignment is really tied to the triple aim. So it's not purely just a financial thought process, but it's really driven by quality, which lowers costs and improves satisfaction. That physician leadership input is from those who help drive patient value. And it doesn't necessarily have to be level one, but ultimately as you work your program through and get alignment from it, those clinicians that are driving value have an opportunity to create input. That there's good transparency between physician leaders and network participants. I think most ACOs are really good at having physician leadership and physician integration. The alignment or transparency in the network participants tends to be a little bit more difficult because it's a larger work effort. So some commitment to that is really critical. This next one I don't think can be underplayed or overplayed, but to keep it simple, I can't tell you, particularly in groupthink environments with lots of really bright people involved who really understand the puts and takes of cost and quality in the medical arena, how complicated and how easy it is to get to a very complicated methodology around distribution and around payouts. And so at least early on, really do recommend keeping that structure as simple as possible. Really does help drive transparency and understanding. And it's easier to layer in complexity as you go based on a solid foundation of understanding and trust. So really do kind of encourage that. Focus on the aligned incentives by distributing the savings, the value, the savings and the value to the participants who generated it, which is a little different than a couple of sentences above where we said who drive value. So you may look at it on a specialist perspective in 3 or in 2, but in 5, there's some literal, if you have high-performing groups or high-performing folks, that there's some component that leans towards them that really allows that alignment to occur. And that bleeds into 6 as well, which talks about the fairness factor. And so, making sure that those in the network look at what we're doing and say that's a fair distribution of funds, or because if they don't, then that starts to, or that really erodes buy-in. We believe that a good citizen requirement is important. I personally was involved in an ACO, running an ACO outside of the state, where components of the network were outside of the state of Florida. And one of the participants decided one year that they no longer felt it was important to support the GPRO process. And so we had to explain to them what the financial impact of their thought process was, as well as what it meant to the other physicians in the network, and ultimately able to provide some assistance to take that burden off that group that was just going through some internal turmoil. But that good citizens requirement is making sure it's fair and is important. But do believe that there's a basic number of almost pass-fail type activities in the good citizen requirement component. Once you go through all the pain of establishing your approach and process, we do believe that it makes a ton of sense that your leadership should be flexible and reevaluate this on at least annual basis. You're going to have better data. You're going to hopefully have better infrastructure and technology over time. You're going to have providers added, and you want to make sure that your alignment of your program to key priorities grows with your ACO. So do believe that really is important. A common concern is, how does my ACO payment affect the physician's compensation? And what we really recommend is that you don't confuse those two. The ACO comes up with a fair method. It treats folks within their program, whether they're employed or non-employed, if it's a hospital system led, in the same manner, becomes defendable. So really, don't get confused and start treating physicians differently based on their other sources of revenue, and recognize that reasonable overhead costs and infrastructure improvement do have to occur as you think about your model. I know that it's tough sometimes to consider that because of the amount of work and effort that the physician community puts into the success of the program. So if you think about what we just talked through and kind of the flow, payment flow considerations, it's a good opportunity to think about what would be your minimum good citizens requirements, and really kind of require a pass-fail. I mean, there's just a minimal set of activities that everybody needs to do, or every group needs to do, to make sure that that we're not jeopardizing our opportunity to recoup the benefits of the hard work of improving quality for the members we have accountability for. We do believe that you start with attribution for distribution, and then add in the success within quality measures. If you're a little more advanced, then you add in gap closures and care programs as you see fit. From a hospital side, generally focusing on return on investment and future infrastructure enhancement, align incentives to ensure that they're involved in cost reduction efforts. So if we're pulling a lot of cost out, there's an opportunity to get some reward back. And then for hospitals, we always recommend to get involved in HQEP. HQEPs are programs where hospitals and associated physicians, generally specialists, but not always, but generally specialists, look at opportunities to improve processes within the hospital and have shared savings. That does two things. It helps the hospital improve their cost structure, and it also gets the specialists within your program involved in other revenue enhancement programs as well. And then we've talked a little bit about specialists already, but understanding that the care programs really need to be well thought out, well understood, and aligned to what helps drive benefits for the ACO. So as we think about what we just talked about and then kind of the weighting, and we talk about attribution, that core attribution really, as kind of a foundational thing, we should think about what are the number of attributed lives brought in by group, and then for MSSP ACOs, ensure that there's a strong focus on the G-Pro measures supported. I've used, I think, a similar example, but we've worked with groups where the focus has not been on the G-Pro measures, and some of that's driven by the dynamics of the leadership group that's driving the clinical work team. But at a minimum, really making sure that we attain our thresholds on G-Pro is really important. There's, as we started our conversation, we talked and recognized 4 ACOs in the state of Florida that were in the top 10. The other component of that is that the increase in ACOs that received shared savings for last year went from almost 70% to almost 71, almost 30%, almost 31% of ACOs, which means we're in the 69, 70% of ACOs not getting shared savings, and roughly half of those saving money or improving the cost of healthcare. And so at a minimum, if we want to make sure that we're putting ourselves in a position to hit our goals, doing the kind of the core basics that CMS wants us to do out of the program is the right starting place. I'll move on now to care programs, now that I've finished my little soapbox there. The care programs, breaking down things into very targeted value-adding elements with assigned responsibility, whether it's by specialty group, or individual physicians. But working through a process so that best practices are identified and that those can be shared to ensure that per specialty there's realized savings. In a pure primary care prevention initiative, there's generally some dynamics because there's a referring component to it, but if it's a pure primary care initiative, look at keeping the funds with the primary care. If it's a multi-specialty initiative, it really needs to tie the percentages to the amount of contribution that occurs within that group. And then early on, one of the things to consider, because people, I think they get a little sideways on this, is the complexity of some of what we just talked about in the care programs can be a little much for an earlier, year 1, 2, 3 ACO. It's not the end of the world to support kind of traditional fee-for-service logic and saying that in categories, if we lower cost, we're going to attribute savings to those that historically bill in those categories. It's easily understood. It gets alignment. And it's a good foundation then to move up into care programs. There are clearly some concerns with it, like it may not always recognize all the folks that did the work. We may have implemented a care program and it had downstream impact, and step back from those, understand those, but we really want to make sure that we don't let good get bogged down by our desire to be great. And I do think we should all desire to be great, but good is a nice step on the way. And so let's think about how we evolve to condition-specific and episodic-specific type programs. And then lastly, once we understand our measures and our approach, we need to make sure that we're measuring performance and coaching processes are put into play, because it really is critical, because you ultimately want everybody to receive the rewards for their efforts. And if folks aren't ultimately able to do that, we really need to figure out why. So here's two examples of models, and there's nothing wrong with either one of these models. Clearly the one on the right is kind of a foundational model. They're rarely this simplistic, but it's kind of the most common start. And that's looking at your allocation divided by your total patients, that's your savings per patient. Your savings per patients, multiplied by your attributed patients per physician, and then some type of relative weighting based on your quality score. So by 10, you literally get here's my list of quality scores, this group got an 85, this group got a 92, and look at a relative weighting for the entire payout that's set aside for this group. So if somebody loses by having a lower quality score, somebody else's percentage might go up a little bit. It adds a tiny bit of complexity to it, but it does direct resources to folks that are performing at a higher level. Compare that to more of what we call an incentive model, where there's, and this is a little bit more complex, but to make sure that there's some participation component to it. There's then an attribution component layered on top of that, and then a performance component layered on top of that. Again, there's a lot of positives because it makes sure that there's a little bit of funds that everybody gets some component of, and then it rewards the growth and the performance. So there is some benefit to all, although in some cases maybe doesn't align all of the rewards with those who contributed to them quite the right way. But it does create a different funding process, where in the performance model to the right, you might have a separate bucket for the other physicians in your network. In your incentive model, it might include all, or it could include all primary care, but it creates some all providers bringing attributed lives, but it provides a small base of revenue for everybody, and then layers on attribution and performance. Just two different models for folks to consider as they talk through. There's a variety of them. It's not hard to find them, but basically, it's participation plus attribution plus performance. And participation just doesn't mean just in the network, but in the programs, in the I'm just spacing on this word. On all this core stuff you want somebody to do to support the program, GPRO, and those type of things. So just making sure that there's the right type of alignment, and those things that the organization expects out of the network are supported by the model or the program they put in place. So when we talk about guidelines for distribution, and we referenced earlier that should be separate or distinct from physician compensation, we wanted to spend a little bit of time talking about that and the thought process behind that. The focus should remain on shared savings and bonuses received. It should not consider the comp program, because that's going to create a variability in the way you do shared savings and thereby create a lack of defensibility. It is really the accountability of the medical groups, the practices that have responsibility for the physician compensation packages. The ACO should maintain the base distribution and provide that distribution in agreed upon methods. There are going to be those cases where, and there are, and I've had some different experiences with this, where distribution goes directly to a 10, and then the 10 has accountability for providing incentive to the individual physicians within the 10. Believe it's a better in class business focus to make sure that as the ACO, there's some form of general expectations, if not literal form of expectations on how those funds are distributed. I have been part of an ACO where funds were distributed to a 10. The 10 was literally, run by an individual who chose not to pay out any of the ACO funding to the individual physicians. There was a lack of, as you might say, a lack of satisfaction of those physicians' participation in the ACO and doing what they thought. And so it did create quite a mess that I understand is still going on today. So, making sure that there's some type of formal understanding that the rewards that are received are going to be distributed within the guideline of that, within the context of that organization, but that there is something that's consistent based on that. And from there, we'll kind of get to a wrapping up place, and I think we're getting close here. But in conclusion, we want to make sure that we're keeping it really simple, fair, and transparent, at least initially, and adding more sophistication to the program over time. The following guidelines are really, hope to help drive success within the program. We want to make sure that our physician leaders are involved in decision making. They're involved in the design. They can speak to it. They're willing to represent it. Those are really, that's really critical component. We understand that, we can't pull physician leaders to be data analysts, to do lots of modeling, but they need to understand the programs and be willing to support those. That all that are involved, and that it's important to understand that this is a practical approach, that it does line up to the goals and the objectives of the organization. That the process is transparent and participative, that there is an opportunity to provide input and feedback. There's also an understanding that the process will evolve over time, and so that if there's feedback or concern or a desire to bring in additional types of care programs, that there is a process for that. We hear this periodically, and that's a concern that it was done behind closed doors, and it was done by others that were involved. And so, if you're in a group and you have both employed and independent physicians, and we're working through this type of process, we recommend that you get a key physician and an independent physician leader involved before we're announcing what the program is. That goes a long way into making sure that the independents believe that they were involved in the process, and it helps if that independent physician is also willing to help communicate it. And then for those citizen type components, the word I couldn't remember earlier that just came to my head, those kind of key reporting processes are vetted and they're understood, and we understand the burdens those programs put onto the practices, and that we receive any feedback around those and we address those prior to it being the 11th hour. I think it's really key. A couple other components that we wanted to spend a few minutes on. One of the things we recommend, and it really relates to the quality measures, but there's a lot of complexity in the marketplace when you start talking to various groups within your integrated model, and they're feeling like they have to keep track of the kind of the HMO measures, the Humana measures versus the Blue Cross measures versus the MSSP measures versus the. And where you can, we know it's not perfect, but where you can, what we recommend is actually shielding them from all of that variability and just having a single set of quality measures. Now, we do know that the complexity in this is when you have a single care experience and there's different ways to report on it or different requirements related to that by the different payers. But as much, particularly in your contract negotiations, as you can do to kind of keep those as consistent as possible, we do believe that goes a long way in helping minimize some of the impact to the physicians. And then as you refine kind of your operations and what you're doing, you're going to find the use of actual data and improvements in your capabilities and technologies is really going to go a long way to improving the organization and your ability to obtain shared savings. Again, we know that the longer you're in the program, the greater your likelihood of obtaining shared savings, the quicker that improves. And so we just want to make sure that there's that mindset of continual improvement to make sure that we're incenting maximum performance. And then, in conclusion, I'm going to, this is what we said when we started this discussion. It's what we're going to say when we end this discussion. But to the best we can, we want to make sure that the alignment of incentives is clear and that distribution in our programs is really as best we can in proportion to contributions. It's easier to defend, it's easier to understand, and hopefully drives transparency, satisfaction, and buy-in. So I think with that, I want to thank everybody for their time, and I think we have maybe time for a question or two, as long as they're not hard.
All right, John, we did have one question. Manuel Lopez asked on slide 18, how do you allocate savings based on quality scores when CMS does not provide quality score for each participant?
Yeah, but they do by 10. So I think what we did with one of the ACOs I ran is we used the percentage by 10 that was provided. And so, and because with that ACO, we were also providing the savings by 10 back to the group. So for the 10, so it was an individual, again, we knew their individual scores, we were able to pay them as an individual. If the 10 included 10 docs, we knew what the average quality score was, and we used that. And then really our philosophy on that was that it was within that group's accountability to help improve the performance within their group. Because at that point in time, you're like 2 steps away. So you want to drive change to where change can be made.
Manuel, does that answer your question? Did you have any more for John? All righty. Well, I don't see any more questions listed at this time. Manuel did say thank you, so thank you for that, John. And this does have your contact information?
Yeah, I'm trying to put it up, but I'm really just doing a bad job of it.
It's okay. Technology never, works for us. Oh, there it is. There is John's contact information. I will also attach it in the webinar once it is available for me to share. And I just want to thank you for ultimately being a business partner of ACOs and for providing this information to our participants today. And we thank you for that.
Thank you so much. We really appreciate the opportunity and look forward to doing many more fun things together.
Awesome. Thanks so much, John. And thank you to all of our attendees. And take care and have a wonderful Wednesday.
Bye-bye.